Hello, ma'am. Hello. Hello, Shweta, ma'am. Hello, Shweta, ma'am. My screen is visible now.
Yes, ma'am. Hello, ma'am.
I put it on the slides.
Yes, ma'am. It's clear. We will start today's section. Learning is the beginning of wealth. Learning is the beginning of health. Learning is the beginning of spirituality. Having a heart to start learn is where the miracle process all begins.
Good evening, everyone. With great joy and immense pleasure, I extend my warm welcome to all dignitaries, guests, and delegates present here for the Dr. Sudhir Raj N Memorial Free Webinar Series organized by DIKSHA E-Learning in association with Ayurveda College Coimbatore under the banner of Azadi Ka Amrut Mahotsav. In today's session, we will be discussing about clinical concept of Vishamjwara Pathogenesis by Dr. Hrishita S Dahil.
Before starting the session, I would like to go through few of the basic instructions to be followed throughout of the session. For uninterrupted class session, use laptop with high-speed internet connection. Please make sure your microphone is on mute to have a disturbance-free section. In case of any instruction, please check your internet connection firstly. And if the problem is within your network, kindly raise the issues in the chat box. Filling your full name to be displayed is appreciated. Any question can be raised, posted in the chat box. Question raised, we will clear at the end of the session. Next, I could like to invite Dr. Devi, Associate Professor, Department of Roga Nidana, Ayurveda College, Coimbatore, to deliver the welcome address.
Thank you. So welcome all to Dr. Sudhir Raj Memorial Webinar Series conducted by Ayurveda College Coimbatore, and the platform is provided by DIKSHA E-Learning. So one more wonderful Wednesday evening with shower of knowledge. So today we have Dr. Hrishita S Dahil, Ma'am, Professor and HOD, Parul Institute, Roganidana Department, Parul Institute, Gujarat. Ma'am, we are extremely happy to have you today. So ma'am is going to detail on the concept, the pathogenesis of Vishamjwara in Bhel Samhita with special reference to CRS. So I also would like to welcome the clinicians, tutors, and the students who have joined with us today. Welcome you all to the session. Thank you.
Thank you, ma'am.
It is a great pleasure for me to introduce our guest speaker, Dr. Hrishita S Dahil. Ma'am is currently working as professor and HOD of Roganidana and Vikruti Vigyan, Parul Institute of Ayurveda and Research. Ma'am has teaching experience of 11 years for UG, 14 years experience of consultancy in Ayurveda and modern medicine, and experience of pathology consultancy to commercial laboratory. Ma'am has attended many seminars and has delivered many guest lectures. Ma'am has published 4 international journals and 4 UGC careless journals. Ma'am has presented papers in various national and international seminars. We are extremely privileged to have you here in this platform, ma'am. Now, without any further ado, we will turn the time over to respected Dr. Hrishita S. Dahilekar, ma'am, to enlighten our minds with her knowledge.
Thanks, Shweta, ma'am, for warm welcome. I am very glad that I have been invited on this platform of the e-Diksha learning, which is conducted by the Coimbatore Ayurveda College. And this e-Diksha learning is following the footprint that is laid by the late Dr. Sunil Raj sir and Padma Shri of the Krishna Kumar. So now I am presenting the today's topic, that is the concept of pathogenesis of Vishamjwara in relation to the CRS. Now I will share my slide first. Okay. This is the clinical concept of Vishamjwara pathogenesis in a Bhel Samhita with special reference to CRS. So the first thing, that is the Bhel Samhita. It is the ancient Ayurvedic text and it is contemporary to the w.s.r.to Samhita. And as you know that the Maharshi Bhel is one of the 6 students of the Atre Punarvasu. But this Samhita is interrupted as the Khandita Samhita, what we call this. But it is very informative. But some things that now revealed in regarding the Bhel Samhita, that the Bhelacharya basically define the Kalchikitsak word, that is these are the physicians who are treating the Agni disorders. Again, they explain the size of the Jathar-Agni and types of the Alochak Pitta, that is the Chakshur Vaisheshik and Buddhi Vaisheshik. And the basic thing that they explain, that is the regional diet habitat and their related common diseases which are found in that particular regions. And also a part of the Rog Nidan, that is they explain in deep, that is the Vishesh Dhatu Drishti due to the Pitta dosha. But though all they are explaining all these scientifically Ayurvedic things, but it is influenced or it is suggested that, or it is supported that basically they explain the Vyadhis in 2 types, that is the Doshaja Vyadhi and Karmaja Vyadhi. They get influence or they get emphasized basically on the Karmaja Vyadhi and the treatment basically the Daiva Vyapasya Chikitsa. Though it is said that, but the another beauty of their Samhita is basically the Vishamjwara Chikitsa. In the Jara Nidhan Sthan is not available in the Bhel Samhita, but there is a separate chapter of Vishamjwara Chikitsa. So again that we get a separate chapter, and here he explains the unique elaboration of Vishamjwara pathogenesis. And this elaboration is related to the involvement of the specific dosha dusha on the successive days. And this is the unique presentation, and this presentation may resemble or it shows resemblability to the cytokine release syndrome which occurs in malaria, and so it provides a new aspect of CSR grading, and this is my presentation topic actually. So all of you know that the Vishamjwara, that is it is a Vishamavegi Jara Vegata Chapi Vishamjwara Vishamasmritaha, that is it is its nirukti. And Vishama Aramba Kriya Kala means its onset and its propagation, propagation, and then symptoms. There is a variety of difference. So it is a Vishama Aramba Kriya Kala. Muktanubandhitam, again there is a spike of fever. So it is called a Mukta Anubandhitvam also. And it is the Malakala Bala means that is it is the Malakala Bala and Dosha Dusha Bala is responsible for that the manifestation of the Vishamjwara pathogenesis. And in our Samhitas, it is said that it is a Sannipatika Chara, basically. The Tikshnata, Vishamagata, Dujaya, and Tarunata, these are the points are given by the Kashyap Samhita Khilasan. Actually, Kashyap Samhita and Khilasan, they explain that is the Samajwara and Vishamajwara. In that way, they explain that is the Tikshnata, I mean, it's a Ugra, that is, it is very difficult to cure. It's due to its Vishamagati, and it is very durjay, means it is very difficult to treat also. And it shows Daruna means severe symptoms are seen. So these are the in general characteristics of the Vishamjwara that we found in our Samhitas. First, basically, we see the Vishamjwara in short, whatever in our Bruhatri explained, and then we will compare with it, Bhel Samhita. So it will be easy for you to understand the basic difference of the pathogenesis between these two. So the Vishamjwara Nidan that is told in our Grantha, that is the Nija Hetu are there. That is the Krushanam Vyadhi Muktanam Mithyaharadi Sevanam Alpopi Dosha Dushya Labdhata Annato Mato Balam. Then means it is a Nija Hetu actually, and these are there is a presence of Alpabala Dosha. And this Alpabala Dosha may be due to the previous diseases, previous fever also. And when these Alpabala Doshas are present, and at the same time there is a conjunction of a continuous Nidana Sevan, and this Nidana Sevan also responsible for the again pathogenesis. Another is that there is a Sannipatik Hetu are also related because it is a Sannipatik Jwar. And the last thing that is it is called the Agantuja Jwara, Kechit Bhuta Bhushangha Bruvate Vishamjwara. So Bhutanga Bhushanga means it is related to the microbes or pathogens. It also we get reference in our Samhitas. Now, Nidan in Bhel Samhita, if you go there, that is there explain the Kechit Vatatmakam Prahur Vishaja Vishamjwaram, Sannipatodvam Kechita Aparipitta Sambhavam, Shleshmajam tam apare Prahur apare Bhuta Sambhavam, Janma Nakshatra Pida Bhi Parapare Deva Chintakaha, Idrusha Shastrakarana Mayato Prithakvidaha. So again they explain that is some Vishamjwara is Vatatmaja, and it can be that we know that is the Vishama Veki. Some are Pitta Pradhana, Pitta the dominancy, that we can't call it the Dahapurvaka Jwara, it can be resembled. Shleshma Jwara, Shleshma means there is a dominancy of the kapha, and so it may get the Shitapurvaka Jwara. It is Sannipataja, again there is a Tridosha Dushti. Bhutta Sambhavaja, it again comes the Agantuja, and they also explain the Graha Badhaja, which comes under the Abhicharaja and Abhishavaja types. So whenever the Bhel Samhita explains these types, but the last sentence is that is all the Vishamjwara are Sannipatik, is their own opinion, and it is same as that of the Charkacharya also. Then we go to Samprapti, that is in our Bruhatri, what we see, that is a Doshaha Pravartate Tesham Svekale Joren Bali, Nivartate Punushesha Pratyanika Balam, Shina Doshe Jwaraha Sukshma Rasadisha Evadiyate, Dinatvat Kasha Vaivaran Radadinam Dadhati. Then the famous quotation of the Sushruta Uttarasan that all of you know, that Dosha Puhita Sambhuto Jora Sushti Sava Punaha Dhatu Manyatam Praptam Karoti Vishamjwaram. So basically when we see that there is a Lina Avastha, again there is a Alpabala Dosha that lurk in the Dhatus, and this is a Lina Avastha, and this Lina Avastha causes the Karsha, Vaivaranya, Radadin, all these symptoms basically. And when Dhatus, when doshas in Lina Avastha, they get vitiated due to the Mithya Nidan Sevan and increase their dosha Rushya Bala. And after that, at the same time, they increase their strain due to the Kala Bala, and this Kala Bala, they get strained due to their Prakruta Dosha Gati. That we know that is the Prakruta Dosha Gati, that the Vaishamyam Gati occur. So in that way, when they get Dosha Kala Bala, so then again the Sthana Samshaya, in that Sthana Samshaya that we get Dosha Samuchna, it invades the Dhatu, and in Vattavastha we get the Vishamjwara Vegavastha. But basically this Vishamjwara Vegavastha is due to Vata Dosha. In Sushrutacharya said that Velang Tameva Kurbanti Jwara Vega Murmuhu Vatena Udhyamanasya Yatha Purate Sagaraha. Again it is reflected Krutva Vegam Gatabala Sveshve Sthane Avastitaha Punar Yurudha Svekale Joranti Naramala. Means after the Vyakta Avastha, then again that goes into some doshas again called Lina Avastha, and again when they get Bala, according to Dusha and Kala, then again the symptoms occur. So this is a vicious cycle, and this is Samprapti of the Vishamjwara. And the types of the Vishamjwara that we found in our Samhita, that is in Charkacharya, That is total. There are the 5 types generally that we see that Santata, Satato, Anyansa, Trityaka, Chaturthako. All these types are explained in all Samhitas, and there are the 5 types. And in Charakacharya that we get the sub classification regarding Trityaka Jara, that is Shirograhi, Pushtagrahi, and Trigrahi, and they explain the type of the Viparya, that is the Chaturthaka Viparya. And in Chaturthaka, they explain again the sub classification of the Pedigagrahi and Shirograhi. In Sushrutacharya, they explain the all the classical 5 types along with Viparya, all these types, and they also explain the Pralepaka and Vatabalasaka. This is Vatakapajatmak, this is the Jwara actually, and but they consider it as the complications of the Vishamjwara. Then in Ashtang Sangrah that we found, that is the 5 types of the classical Jwara, and then they explain other types, that is the Ratrika and Purvaratrika Jwara. This is the pattern of the basically that this is when fever occur. Actually, in Ratrika Jwara, there is a rise in fever due to the Samavat and Kapha, and in Purvaratrika means there is a fever occurrence during the daytime, and this is due to the Hina Kapha. In Madhava Nidan, they explain 3 more types actually. That is the Ardhanarishwara, where there is a enlargement or lodgement of the basically doshas in which part of the body. So it is ideal to the Ardhanari Nateshwara. So the half part of the body is feeling hotness and the half part of the body feeling coldness. So in that way, it is the Ardhanari Narishwara Jwara. Then it explains the Shita Purvaka Jwara and Daha Purvaka Jwara. And in Shita Purvaka Jwara, there is a dominancy of Vata Kaphatmak, and it is Daha Purvaka, it is a Kapha Pittatmak dominancy. Then this is again the classical things that I have I'm going to show you, that is the Satatam Rasaraktasna, so Annendu Pishita Shitaha, Medogata Tutheni Asti Manchakataha, Punaha, Purya Chaturtakam Goram, Anantakam Rokasankaram. So according to Charkacharya or according to physician, they specifically involved doshas, means that is a Santata Jwara is a Rasashray, it is a Dwadasha Ashray Bhava, there is a Nishpratnanding. All these are you get in the classical text, and the clinical presentation, it is a continuous type of fever. According to the Sushrutacharya, there are the Kapasthana involvement, and in Santata Jwara, there is the Amashray. Then next type is Satata, and involved dosha is Rakta, and the fever rises twice in the 24 hours, and involved Kapasthana, that is the Amashray and Pura actually. And then Dushka, that is according to Vagpat, it is a Mamsa, Vishitashrita, but in Charakacharya, it is in considered as it is a Mridashrita, and fever rises only once in a day. And according to Sushrutacharya, the Kapasthana, Amashay, Ura Kantha, so it takes the times from the Kantha, Ura, Amashay, and then the symptoms of the fever occur. So this is the way of manifestation. In the Trityak Jwara, according to Vagvatacharya, it is the Medashrita, and Charakacharya, it is the Asti Manchakata, and fever appear on the 3rd day. And again, there are the one more Kapasthana involved, that is the Shirasthana here involved. And in Chaturthaka Jwara, it is the Asti Manchakata, fever appear on the 4th day, that is the Dwabdham Vishramdham, means after 2 days, there is a remission of the fever, and then again you can find the fever on the 4th day, and there is the Kapasa involvement of the Amashe, Ura, Kanta, Shira, and Sandhi. So all these related to Vishamjwara, what you learn in the Samhitas. But when we see the Samanya Samprapti in the Bhel Samhita, they have given that is Sanni Patodbhavam. Actually, I told you that they are mentioned the Vataja, Pittaja, Shleshmaja, Graha Sambhavaja types, and again they explain as Sanni Patodbhava. So they underline the word Sanni Patodbhava, that the Tridosh involvement is there, but dominancy of the Vata dosh. So that dominancy is also reflect in their Samanya Samprapti, that is the Pakva Shayasta Pavano. So again, they get a Pakva Shayasta Pavano, the Asti Majjagata Tatha, Kupitaha Kopetu Ashu Shleshmanam Pittamevacha. So Gambhira Samutpatti Sthana Tantryo Mahano, means here we can tabulate this Samprapti in the way that is the after the Nidan Sevan, actually there is the aggravation of the Pakva Shayasavat, aggravation, and then it vitiates the Asti Majja Dhatu, invades that Dhatu basically, and then they vitiates the Kapha and Pitta, and Vishamjwara symptoms occur. Though again it is a sannipathic Vatadosha. So basically the Pakvash is the Pavana and it Vishesh Asti Majjagata, it is their common Samanya Samprapti. Then types in Bhel Samhita that they explain only 3 types, that is the Annendushka, Ekantrita, Kuryat, Abhi Chaturthukam. That's it. That we are not seeing here the Satata and Santata types. Actually in Karanan also that is they omitted, that is the Satata Chora also, because it is a continuous fever and Muktani Bandhitva Kal is very short. But and here again we get that is in Annendushka, Ekantarita and Chaturthaka. So only difference is that is they not use the word Trutiyaka, they use the word Ekantarita. And I think it is appropriate because one day alteration you can alteration the rise in fever, that is spikes you can get, and so word is that is Ekantarita. Then again their main, that is the topic of presentation is that is this regarding the Samprapti of the Chaturthaka Jora, Vishesh Samprapti they explain, and the successive day-wise sequence of manifestation is there they explain. And it is a unique explanation that which are not found in our Charak Samhita or Sushruta Samhita, because their manifestation or their explanation of Samprapti is another way. So here they get a clear idea that is a Majjana Asthimedasya Dushete Prathame Hani. द्वितीये हनि संप्राप्ते दूषेत मांस शोणितम ततस्तृतीये दिवसे दूषेत कफमावृतो अभिगम्य तथा पित्तम दूषेतु चतुर्थके. Means on the first day, that is that we get the visheshan of the majja, asti and medadushti. On the second day there is a visheshan of rakta mamsa, and on the third day there is a kaphavata dushti, and on the fourth day there is a pitta dosha. Then Jaroyam Pranayam Dehe Raudro Maheshwar Tatha Priyatate the Prashantu Tasmat Vichakshana. So again it is last day, it is a Pitta Dosha Visheshan, and it is very difficult to cure actually, incurable type and Darunatva again. So this basic is first day Majja Asti Meda. So it is a unique combination, but they explain in which day. The first day 3 types of the dhatus are involved. On second day Rakta Mamsa, on third day Kaphavata, and fourth day again doshas. So, but again, next thing that is that we know, we should know the Lakshanas. But here this is the Bhel Samhita that you know that it is interrupted and there is nothing, any explanation regarding the Lakshanas actually. So here, but you can guess, or actually you can guess with the authoritative evidence, that we call it the Apta Praman, then logical evidence with Anuman Praman. So considering Vishamjwara, what he said, that is a Vishamjwara is Sannipathajichwara, and symptoms caused by the greater discordance of the Vata dosha rather than other, whatever we get in Sannipathic Jwara. Here I take the some privilege, that is actually the what is the Sannipathic Jwara explained in Charakacharya actually, because Charakacharya and these Bhelacharya, these are the students of the Atreya. So basically here I get advantage that to consider the symptoms, I get the help of this Sannipathic Jwara here. So considering all these things, we can find out what they say actually. So here I consider the Vatolbana Kapha, Kapha and Pitta Manda, that is the in Charak Chikitsa Sthan 394. They explain that is the Sandhasi Shirasa Shula Pralapo Gahuram Brahmaha Vatolbane Sada Dvegune Tushna Kanthasa Shushkata. Again, that is the Vatolbana Kapha Mandya and Pitta Hina, that is the Shiro Rukvepatu Shwasa Pralapa Chardi Arochaka Hina Patta Kapha Lingam San Maruta Adhike. Third thing, that is the Vatolbana Pitta Madhya and Kapha Hina. And so they explain Shwasakasa Pratishaya Mukhashosha Ati Patvaru Kapha Hina Pitta Madhya Alinga Vata Adhitan. And now here consider as a Vatolbana Sannipat, that is it is called as the Vispuraka in Madhav Nidan, and there are the various symptoms, that is the Vatolbana Sannipatos Jarasante Prakutanti Tasya Tushna Jwara Glani Pasharu Dushti Samshaha Pindiko Dveshtana Daha Urusada Balakshayaha Savraktasancha Azvirmutra Shula Nidra Uparyaha Niribhadyante Gudacha Basticha Parikrutate Ayam Mete Vidyate Hikkate Vilapati. Murcha Atisparati Namna Vispuraka Sprutaha. So all these are the 4 types of the Vishamjwara, and here you get a radar discordance of the Vata dosh, and here now we can case or we can analyze the symptoms of the Bhel Samhita also. It will help us. So whenever we say that in Bhel Samhita, we found that the first there is Asti Majja Drishti. So here these are the symptoms that we can analyze from the above shlokas, that is in Asti Majja Drishti, that there may be a Sandhasti Shirashul, Shirorup, Vepatu, Atipashvarup, Brahma, Pralapa, Glani, Vilapa, and Shula. On second day, they explain the Rakta Mamsa Drishti. So related Rakta Mamsa Drishti symptoms are Daha, Sarakta Mala Pravrutti, Sarakta Mudra Pravrutti, Pindiko Dveshtan, Basti Vedana, Buddha Vedana, and again Shula. On third day, when they say the Kapvayu Drishti, so we get the Gaurava, Pratishaya, Hikka, Shvasa, Urasada, Balakshay, Tushna, Kanta Shushkata, Mukha Shosha, and again Nidra Viparya. And on the fourth day, Pitta Drishti, that is a Daha Jwara Drishti Chaya, Saraktamala Pravrutti, Saraktamutra Pravrutti, again Trishna, Kanta Shushkata, and Murcha. So these are the symptoms that we can guess according to Vishamjwara Pathogenesis. So this Vishamjwara, now it is correlated with the malaria, as you know that malaria it is it is basically it is a endemic in tropical and subtropical countries, and it is characteristic that is the fever with chills also, and causative organism, that is a microorganism, that is plasmodial. It is a protozoal infection actually, and the vector, that is the female Anopheles mosquito, is responsible as a form of vector. Actually, prevalence forms in India, it is total in India, actually 3% global death. Actually, global death are basically due to the malaria in India. Now the rate of death due to malaria is now declining in India as compared to 2015-16. But that we not, but India is not declared as a malaria-free country, as the China is declared in 2021 as a malaria-free country. Also, even in Sri Lanka, they are declared as 2016 as a malaria-free country. But now the India is not declared. Our mission is that to get rid from the to at least up to 2030. So the prevalence rate is higher, and but when we see that there is a plasmodial infection, there is a 4 strains actually, that is the plasmodial vivax, that in India it occurs in 70%, falciparum that occurs 25 to 30%, and mixed, that is the plasmodium vivax and falciparum occurs 4 to 8%, and plasmodial malaria it occurs in some southern part, that it is less than 1%. So sometimes that is basic life cycles of this malarial parasite, that is there is a sporogony cycle, then erythrocytic schizogony, erythrocytic schizogony, and 1 minute. The sporogony cycle. The sporogony cycle is basically it occurs in mosquito stage actually, and here in sporogony cycle, that is the sporozoites are inoculated from mosquito to the human body, and in erythrocytic schizogony, that is in the liver stage actually, here that is the inoculated sporozoite, they undergo the merozoite, and then they forms and they undergo from the cynodes first form, and then there is the formation of merozoites, and after that the merozoites are then escape in the through a blood circulation, and then all over the body. So at this stage, then the erythrocytic schizogony occur, and this at the erythrocytic schizogony, basically they infect the RBCs, and then we can get, and the clinical diagnosis at this stage, that we can get identify the ring shape, that is the protozoal infection, that with the ring shape signatory ring that we found on the PPS actually, and then there is a tropozoite formation and a schizonodes. Basically, in erythrocytic schizogony, there is a asexual multiplication of this cycle actually, and in the mosquito there is a sexual reproduction of this occur mosquito. So basically, when the patient starts the clinical symptoms actually in started in patient in this X in erythrocytic schizophrenia. In X erythrocytic schizophrenia, that we see there is a primary attack of the malaria may found. So in the next slide, you can get clear that is in primary attack. That is, it is a X erythrocytic schizophrenia. That is when they first inoculate in the liver, and there is an acute febrile illness, and there is a lesser degree of parasitemia actually there, and may sometimes it is ignored, or it is some mild fever. So some antibiotic and other things that whether patient get relief. But after that, sometimes that is when erythrocytic schizophrenia complete at the clinical stage, and we got this clear idea, clear picture, symptoms of this malaria, and this erythrocytic schizophrenia cycle, it of each species is different. So there is a periodicity is different. And then the third, that is a relapsing stage, and this relapsing state is due to the dormant hypoxonite. Means this dormant hypoxonite means whenever there is a mosquito, there is a sporokinetics when inoculate in the liver, sometimes they undergo dormancy and in the form of hypoxonite, and when they get their exposure again, get immunity, and then the short relapse will occur, and it may be up to 8 to 10 days, and in some cases there is after a gap of 20 to 60 days they get relapse. So what is the explained dormant hypoxonite reactivated then relapsing? So all these are related to the Bhumishete Adhishete, that is what we are explained in our Charak Samhita. So it can be correlated. Then the febrile episodes, that you know that is a cold stage, then hot stage and sweating stage. Cold stage is 15 to 20 minutes, yeah, 30 minutes. Hot stage, maybe it is a fever, it's long time with 2 to 6 hours and it is high. And sweating stage, there is a profuse sweating and it comes gradually slow down of the fever. And again, there are the types, that is the quotidian fever, and basically it occurs in Plasmodium falciparum. And there is basically the erythrocytic schizophrenia means actually it is a time taken for some propocyte to schizoid formation, that is the erythrocytic schizophrenia, and it takes 24 hours. And basically Plasmodium falciparum infect the fresh RBC, new RBC also. So there is a spike of fever rise in 24 hours. There is a quotidian. Then tertian fever, that is there is a it is due to the Vivax and O Valley, and here the erythrocytic schizophrenia cycle is from 36 to 48 hours depending on that species particularly, and you can get the fever on the 48 hours. And the cotton fever, that is the Plasmodium malaria, there is the erythrocytic schizophrenia cycle is long, that is up to the 72 hours, and so you can get on the fourth day fever. So it is the basic things, and now there are the clinical manifestations that you can see in malaria, that is the anorexia, tiredness, joint pain, muscle ache, headache, fever with chills and rigors, nausea, vomiting, diarrhea, and dyspnea. And these are the signs and symptoms. You can see the hyperpyrexia, anemia, jaundice, and anuria. Again, if it is severe, then you can get pulmonary edema, thrombocytopenia, disseminated intracoagulopathy, hypovolemic shock, and coma. So from general symptoms to severe symptoms, it is the vast manifestations of the malaria, and in these basically the CRS, the cytokine release syndrome, play important role in this clinical manifestation. And here the tumor necrotic factor, interferon, and interleukin 1, 6, and IL-8 play the important role. Here you can see this is the basic pathophysiology. What is the role of cytokinin in the formation of the malaria? First, when this sporokine at the erythrocytic schizophrenia cycle, when the merocytes ruptures from the ruptures and they come out from the liver and circulate through the blood and they infect the RBC. When they infect the RBC, they basically degrade the protein material, they degrade the hemoglobin material, and they form the malarial pigment. And at the same time, the infected RBC then again release the merocytes also. At the same time, they release the GPI, that is the long term. It is actually the the type of the toxins, glycosylated phosphorylated activated is the GPI. Then this basically GPI, it activates the monocytes and endothelial cells, which are our the primary defense mechanism cells, that the immune cells, and these cells secrete the cytokinins and pro-inflammatory markers. And first is that the first depends the help in prevention of early infections. So at this stage, you can get the constitutional symptoms like chills with fever, then sometimes loose motions, and sometimes anorexia and vomiting. So all the constitutional symptoms you can see here, basically they are to help in prevention of the early infection, to lower the grade of parasitemia that which occur in the bloodstream. At the same time, this malarial pigment which is formed due to the impaired hemoglobin metabolism, and there is also the structural changes in the RBC, that all of you know that is the RBCs are biconcave, but due to this malarial pigment formation and other things, that is the structural changes of the RBC, and there is a hemolysis, RBC destruction, and it causes the anemia. When there is structural changes in the RBC, it causes a cytoadherence. So what is mean by cytoadherence? Cytoadherence means it is the RBC cell wall become rigid and it get affinited to attach the epithelial walls. So they get attached to the epithelial wall, and it is cytoadherence. After that, there is a resetting, means there is a that infected RBC then get attached to the normal RBCs. So it is a vicious cycle. So it infects the normal RBC, and then there is a sequestration of that particular unstructured RBCs and in the various organs, and these organs are basically the heart, lung, kidney, adipose tissue, or erythropoietic system. So these are the various organs which are involved in our particular metabolism are required, and in that sequestration, if this cycle is going on, means there is a cytoadherence, there is a resetting and sequestration. This is uninhibiting cycle and it is going on, and so again it causes a decreased capillary circulation, means it then causes the blockage of the capillary vessels, and so there is a tissue hypoxia. Again, when we see that hemolysis anemia, then it again causes tissue hypoxia, and tissue hypoxia leads to the organ toxicity. So there is the less oxygen consumption, oxygen to the that particular cells, and this organ toxicity develops means that particular organ, whichever may be involved, it may be liver, kidney, brain, all these organs, is the impairment of that their functions, and again that organ toxicity increases cytokinin. Here, that one more thing that is a when there is a first thing that is a help in prevention of early infection, cytokinins are released. So in the first stage, but there is a failure to inhibit the immune response. It is a basic thing. Again, for cytokine release syndrome, means it is that is inhibitory cycle. It is that we can there is a failure, and so there is an exaggerated immune response, and there is a more cytokinesis, and more cytokinins are released. Excessive cytokinin release. Also, one more thing that help in cytokinin over secretion, that is the plasmodial DNA. If that the plasmodial DNA actually it is basically involved, and it causes actually cytokinin more cytokine secretions, and so that we get the CRS symptoms. And when the CRS get activated or cytokine release symptoms get activated, again there is a activation of the platelets. First they are infect the RBC, second time they infect the platelets, and when the platelets function get impaired, you can get the coagulogram is there difference, and so you can get the DIC related disease, disseminated intracoagulopathy, and finally it may lead to death. So this is the basic relation of the CSR. Now when you see that CSR, the basic thing is the cytokine. So what is cytokine? Cyto means actually cells, and kine means it is the movement. So whenever our immune system is in threat, there is when you want a first sign of defense, actually the cytokines are secreted by the immune cells. That the immune cells may be a macrophages, granulocyte, lymphocyte, mast cells, maybe endothelial cells. So whatever that in general in malaria it is from the macrophages, it is generally secreted. The cytokines are secreted actually, And these cytokines, they basically involve immunity and they aggregate of the blood cells at the inflammatory sites. So they actually enhance the movement of the blood cells, that is the RBC and WBC platelets cells at the particular inflammatory sites. And these cytokines are of two types, that is the pro-inflammatory cytokines, that is the interleukin 1, interleukin 6, and there is the tissue necrotic factor like alpha, and some are anti-inflammatory cytokines, that is the IL-4, IL-10. But here that some interleukins play a role in, as they are at certain limit, they act as an anti-inflammatory. But after that, if your control, that is the immune control, is lost or there is excessive, then they turn in as a pro-inflammatory cytokine. So here you can see IL-6, it is a very important that sometimes it acts as anti-inflammatory, and in some diseases it acts as a pro-inflammatory cytokines. So when we see that is cytokine release syndrome, it is basically a systemic inflammatory response actually. And this syndrome was first coined in early 90s, and it is actually the result between the anti-inflammatory and pro-inflammatory cytokines actually. And whenever this cytokine system as CRS occur actually, it affect all over the body and we get all the systemic symptoms. First, that is the unspecific symptom, that is you can get the fever, fatigue, anorexia. If it is related to the lung, that is in respiratory system, if it then you can get tachypnea, hypoxia, pulmonary edema, respiratory failure. In renal system, that you can get the acute kidney injury, renal failure. And when they affect the liver function, that is you can get the hepatomegaly, elevated liver enzymes, and hypoparathyroidism and liver failure last time. And when affect the heart region, basically you can get tachycardia. There is a changes in also ECG also, and hypotension and troponin elevation and arrhythmia, QT prolongation, that's the changes you can see, and cardiomyopathy and acute heart failure at the last stage. And that you know that when it affect the erythrocyte cycle, that is the cytopenia, coagulopathies are increased. You can see the PTT is increased, INR is decreased, and you can find the DIC. So it is the in general CRS symptoms which occur in the malaria. So one more thing that here I want to explain, that is the word I am using, the CRS, that is cytokine release syndrome, and now the word that you are using in COVID, that is the cytokine storm. So what is the difference between, actually CRS and cytokine storms are the same related cytokines, but it is depend upon the duration. Means in CRS, the symptoms may be delayed until the days or weeks after the treatment, and depending on the kinetic of T cell activation. So it takes long time. As we can see that it is a chronic, but it is not the cytokine storm. The T cell activation and the clinical symptoms occur within a minutes to hour or treatment. So here we can compare that in COVID situation, that you can get a cytokine storm, that is it's very fatal and to treat. The basic key mediators are in CRS, that is IL-6 is a key mediator, and in cytokine storm it is a TNF alpha is basically key mediator. And all these are the laboratory tests for cytokine storm, that is the CRP, cytokine ESR, then neutrophil lymphocyte ratio, ALT, ferritin level, D dimer lactate dehydrogenase. So these are the laboratory values. But here now we are only considering a CRS. So CRS is classified. There are different classifications, and basically the first classification is the CTCAE, the CRS grading system, according to common terminology criteria for adverse effect. So what are the activities of adverse effect? And it based on the patient's response to the fluids, IV fluids, vasopressors, and oxygen consumption. What are the patient is given the treatment? So organ toxicity, but this, though it is CTCA CRS grading scale is there, but it is difficult to standardize. So the pain grading scale is now available, and this pain grading scale is basically based on primary clinical parameters and not the laboratory values of inflammatory markers. So whatever we are seeing in cytokine storm, the laboratory asks you what is the level of CRP actually there, what is the level of ferritin, what is the, all these things are not required in CRS and basically pain grading says. And they classify the symptoms as mild, moderate, severe, and life-threatening. Another, the modified way of the pain grading based on the 2014 V8 algorithm, and is widely accepted because it is based, or it can give the gradation for the cytokine storm, that is the immediate cytokine response, and as well as the CRS. Hmm? So that what we are seeing in malaria, that is the late onset of cytokine response. And these CRS, in that way, they are graded in the first, second, third, fourth, and fifth gradation. Now we will see here this gradation of the CRS, and in grade 1 we can grade the fever, nausea, fatigue, and headache, myalgia, and the required treatment is symptomatic treatment. In grade 2, is the oxygen requirement less than 40%, hypotension, responsive to fluid, or low dose vasopressin. There is a grade 2 organ toxicity regarding the creatinine, and grade 3 LFTs, and moderate intervention required. In grade 3, oxygen requirement is more than 40%, and grade 3 organ toxicity related to the creatinine, and for the LFT it is a grade 4. And here you can require the aggressive treatment. Hypotension require the high dose of multivasopressor, coagulopathy, fresh frozen plasma there. And in grade 4, organ toxicity excluding transaminitis, it is very high, and the patient need ventilator support. And in grade 5, you can find the death of the patient is unresponsiveness to the treatment. So these are the criteria where only the laboratory parameters related to the LFT and RFT are only considered. Here they are not considered any inflammatory markers. What is the level of CRP, what is the level of ESR, what is again the fibrinogen level or D dimer, they are not required. They require a simple clinical symptoms along with LFT and RFT. So one thing that you should know, that what is the organ toxicity related to creatinine, and that is the bilirubin. When there is a scale actually, and in that scale they explain, whenever you say that the grade 2 creatinine, so you must know that is the creatinine normal value, that is about 1.1, 1.2 according to laboratory. And when it is grade 1, if it is a grade 1 organ toxicity, means creatinine levels are increased, that is up to 1.5 times more than the normal baseline. When you are labeling it as a 2 grade, that is that the levels are increased 2 times, and when you are defining grade 3, that is it is more than 3 times. And at the 4th level, that you need basically there is a kidney failure, you need a dialysis actually. Another thing that is, it is depend upon the GFR value, that is the that is the eGFR actually ejection factor, and that less than 15, it is very dangerous actually, and it required the dialysis. And in bilirubin, actually it is needed, sorry, in LFT, it based on the bilirubin levels. In the same way that it is depend, if more than 3 to 4 times more than the baseline, then it is considered as the 4th grade in LFT. So when we see that, so coming to our Ayurvedic point, that is what is the CSR, what is the Ayurvedic perspective, then I can correlate with this, that is the CRS, and basically it is a imbalance between the anti-inflammatory cytokinin and pro-inflammatory cytokinin. It is basic things. So you can correlate, or that that in our Samhita, that they explain that is the doshas, when it is an equilibrium state, that is the dosha prabhava, there is a even dosha showing the opposite quality, that the vata showing opposite quality of the pitta and vata, also some difference in shita, ushna, guratmaka. Also their innate quantities are different, but in samyavastha there is no any rivalry or any, their gunas are not over dominating, they are in equilibrium state. So it is called as doshaha samasatridhara vishamhina. Means in equilibrium, that is the tasmat doshana prabhavam vishwa adhate parasparam anupaghanti, means they are not any dominating, or they not any overtaking to each other, and viruddhayapi, though they are, their qualities are different, not vede gune ghanti parasparam, that is explained. And doshaha samasatridha, that is a sahaja satya. But whenever there is unequilibrium, and this unequilibrium is basically due to the Nidan Sevan, it may be Ahar, Vihar, or various factor, that is Manasik, or this Nidan Sevan, then there is a basically unequilibrium started, and at that time the Viruddha Guna Sannipate Bhuesa Alpajute. Actually, it is given in our text related to the Virodhi Ahar actually, but even you can apply to this dosha actually Viruddha Guna Sannipate when unequilibrium started. That is the then sometimes that is the whenever one dosha is vitiated, it vitiates the other dosha also. If you treat the vitiated one dosha, then again other doshas come also to equilibrium. This is the basic things. And one there is a Viruddha Guna Sannipate, the Bhuesa Alpagate means whichever dominant, it can show their symptoms. And again you can find Rasa Hetu Visheshasya. And in another thing, that is the in Sannipathic in Madhonidan commentary, you can find it very well, which is explained by the Charakacharya also, that the Vikruta Vikrutam Deham Bhanti te Vartanti cha Vikrutanam Ghatakatvam Rogarupena Bhavati. या विकृति सह एव रोग इति दोष रोगयोर भेदः अस्तु वा भेदः मिलितैः दोषः रोग क्रियते इति. So whenever there is an imbalance start, there is a vikruta avikruta deham sannipatik drushti. Explain basically sannipatik drushti. That is vikruta avikruta means that is a normal. Vikruta means that is a vitiated dosha again vitiate the normal things. Avikruta deham also, and deham dhanti de vartenshi means उसका basically उसको overtake करते हैं और उसके symptoms आपको मिलते हैं. Then vikrutanam घातकत्वम रोगो रूपेण भवति. So here basically vikrutanam ghatakatvam means that is pathology that occurs to destroy this vikrut thing. Vikrutanam ghatakatvam rogo rupena bhavanti. So this CRS actually basically it is cytokinin. It is a double S source. First thing, it cover your primary infection. It helps you to your cover your primary cytopenia to decrease. But at the certain limit, then when your immunity goes down and there is the over secretions of that immune response actually, and then it is ghatakatvam rogo rupena bhavanti. So vikrutanam ghatakatvam, that rogo rupena bhavati means it is a CRS. So it is explained in our Samhitas also. Aya vikruti sa rogoeva, and it is correlated as a rogo as it is not dosha rogo, but it is doshoka. It is not the classification. It is actually a disease. And again they explain militaihi doshaha roga kriyata iti. So this is the CRS which are explained. We can get the reference in our Samhitas. So again to coming to the main topic, that is the correlation. Why I explain all these things, because we'll see that in Bhel Samhita that the dosha drushti, that is in first day we get the asthi majja drushti, and meda drushti actually. If you don't remember, and then you can see that asthi majja drushti is there, and in that we analyze, that is the rule out some point out some symptoms, that is the sandhasti shuddha, shirorup, ati pashvarup, and these are correlated with CRS symptoms that you can see here. Grade 1, that is a headache, myalgia, asalgia, and backache. Then Vepathu, that is it is related to tremors, and these tremors in malaria you can see due to the chills and rigors. For the 15 to 20 minutes actually, and Brahma Vilapaglani, which are the Majja Drushti actually related, and here these are due to the hyperparexemia, and here the CNS involvement due to hyperparexia, and you can correlate with Brahma Vilapaglani. So in Asthi Majja Drushti you can get the grade 1 related CRS symptoms. In Takta Mausa Drushti, that is, it is a Daha Shula Shotha, and it is basically related to the fevers, fever, rash, burning, itching, edema. Actually, it is a CRS activation through mast cells. In previous slide, we see that there is a CRS activation, a cytokinin release it from various cells. It may be macrophages, it may be mast cells, it may be plasma cells. So all the immune cells basically which are they secrete the cytokinin, and whenever there is a mast cell, that is histamine is released, and there is itching actually. Itching and burning sensation, and the edema is there. So it is you can correlate with the Daha Shula Shotha, that is it occurs in Rakta Mausa Drushti. Pindikodveshtana. Pindikodveshtana means it is severe fatigue and myalgia, and it can correlate to the cytopenia. That you can see that when the erythroid system, erythropoietic system is affected, basically here in malaria, and there is the RBC destruction, hemolysis, anemia. All these are causes basically, and you can get cytopenia, and here there is the pindicogestion is the main symptom. And but all these basic symptom, DAH, so pindicogestion, it is correlated with the grade 1 CRS, CRS symptoms actually. Then saraptamutra pravrutti, basti vedana. Here you can correlate it with the saraptamutra pravrutti may be due to the altered glomerular filtration, and it again causes hematuria. As we know that there is the RBCs, altered RBC size, and these altered RBC size, it against altered the glomerular filtration rate and causes the hematuria. And in saraptamala pravrutti, basically it is due to the liver impairment, actually saraptamala vasodilation and hemorrhoids. It is the modern pathophysiology behind that. And whenever there is a hemorrhoid, then you can get the Buddha Vedana. So all these are related to the grade 2nd. So in second day in Raktamasa, whenever there is symptoms or vitiated doshas, dominance is more, then you can grade the grade 2nd CRS symptoms. Then in third day, that is the dosha rushti, basically whatever they are seeing, that is the kapha vata rushti. In kapha vata rushti, there is a gaurava arochaka chardi due to the mahasrotas basically, and these are gaurava arochaka chardi. Then you can correlate with GIT related constitutional symptoms which occur as nausea, vomiting, and diarrhea. Again, it is related to the grade 1. So whenever dosha rushti is in small quantity, quality wise, quantity wise, then you can get the grade 1 symptoms. And but when this kapabata drushti, that is, it is occur in Shwasa as a arishta lakshan, and if it is, then it may be due to the metabolic disorders due to the impaired liver functions. That means know that then the impaired liver functions occur, and in that, in last there is a Shwasa, it may be seen as a arishta lakshanatmak. Even hikka, it is correlated with the hiccup, and in severe it is breathlessness in acute kidney, because in acute kidney failure it occurs due to uremia. Uremia means actually the rise in blood level, and actually renal function is impaired, creatinine level is increased, and due to that there is a hiccup, and this hiccup and fast you can see as it is in kapavata dushti, it can be correlated. It is a grade 3rd. Then Shwasa Urasado, it is the result of actually increased pulmonary infiltration. If CRS related, it may affect the respiratory system, then it will increase the pulmonary infiltration and CRS related vascular leakage there, where oxygen requirement is more than 40%, and all the symptoms are seen. And so you can find Shwasa and Urasado. Then Trishna, Kantrishkata, Mukha Shosha, and Nidra Viparya. Nidra Viparya means it is not the insomnia, but it is the altered sleeping pattern also. And basically, Trishna, Kantrishkata, and Mukha Shosh is basically seen due to the hypotension with severe electrolyte balance. And Nidra Viparya, you can correlate with severe restlessness, and again, it is insomnia. And lastly, it is correlated to the grade 3 CRS symptoms. The fourth day, that is the dosha rushti, that is basically only pitta rushti occur. So pitta rushti, in that you can find the daha and joro. Here this daha and joro due to the bhajak pitta rushti, increase in raktamala pitta. Again you so again there is a rakta involvement. There is a impairment of the yakut, or whatever you can say, liver, and here you can get impaired liver function due to severe jaundice. So here you can get Daha and Jwara. Saraktamala pravrutti, again it is correlated with the disseminated intracoagulopathies, and as you know that is the liver function, that is the protein synthesis is basically hampered, and so you can get all these the DIC related symptoms. The Drushti Mandya, it is actually basically the Alochak Pitta Sthana and Alochak Pitta Drushti. So here when we see Drushti Mandya, it is a blurred vision, that is, it is a DIC related maybe retinopathy. It may be seen in hepatic encephalopathy also. So in two ways it is seen, and that you know that in Bhel Samhita and Pitta, actually they are given, that is Alochak Pitta is two type, that is the Chakshu Vaisheshik Pitta and Buddhi Vaisheshik Pitta. So here you can get the Buddhi Vaisheshik Pitta, that is in hepatic encephalopathy, and in Chakshu Vaisheshik Pitta is due to the retinopathy. So in all these you can find the Drishti Manta and it is due to the Alochak Pitta Drishti. The murcha, it again that it may be the hepatic coma, it may be acute renal failure, it may be seen. Okay, so any time of the coma it can be fine. Then daha, jwara and saraktamutta pravrutti and murcha, again it correlate with the acute renal failure, and then due to the electrolyte imbalance also there is a basically the respiratory acidosis is seen due to pulmonary infiltration, and this acidosis and then again it's called the Daha Jwara, the fatal stages, and it is correlated to the grade 4 gradation. So in that way, so we can find that all the symptoms, that is the sequence of the dosha dusha dushti in the Bhel Samhita, that it can be theoretically, not I'm going that, but it is theoretically correlated with the CRS symptoms. So this is the last slide that we can see, that is the final analysis that is in grade 1, that we can raise the constitutional symptoms, and it is the Asthi Madhya Drushti, and this symptom actually can give, that is it is the Alpa Dhatu Drushti basically here, and you have to give the Vatakti Chikitsa. If you go through the Bhel Chikitsa, then they are given the number of Ghruta Kalpana actually basically. So Shodhana Ghruta there are given there for the Vatakti Chikitsa. And in grade 2, that is the hypotension responding to fluid loss, grade 2 organ toxicity, according to our Ayurveda, the Rakta Mahansa Drushti. So again, Rakta Mahansa Drushti, Rakta Vasruto's involvement just starts, so you can give the Rakta Shodhan Chikitsa here. And in grade 3, that is the shock and requirement, it may be Kapha Vata Drushti. So here basically Anna w.s.r.to Drushti and Prana w.s.r.to Drushti. That depending on that particular where the Sthan Samshay, then you can use that particular treatment, that is depend on the Annaguma and Pranavasrutamula Chikitsa. In grade 4th actually, that is a mechanical ventilation related, and it is a grade 4 organ toxicity, that again according to Ayurveda it is the Pitta Drushti and severe Pitta Drushti, whatever we say that, and it is related to Raktavaha and Medavasrutamula Chikitsa. So you have to give one. So actually, this is the CRS triangle actually. So grade 4 to grade 1, actually grade 1 to grade 4 actually, the CRS symptoms like this. But according to Ayurveda, we can guess that that is the, in first grade, there is the Srotomula Drushti is not, it's so deep. After the grade 2nd, the Srotomula Drushti started, and you have to work on the basic as the organ toxicity, that you should take it as a Srotomula Drushti, and you have to take the treatment, you have to do the treatment basically of the Srotomula Drushti, and you can get relief of the symptoms. So this is the beauty of the Bhel Samhita that I want to reveal, and thank you very much for listening, and I think my presentation is over here. Shweta ma'am. Is there any doubt? Hello?
Thank you, ma'am. Thank you so much for your taking your time to prepare for such a extraordinary enlightening section, which is very informative. We will now go again to the question and answer section. Shall we begin, ma'am?
Yes.
Yes.
Thank you, ma'am. Now, I request the delegates to post the question in the chat box. Participants with any questions are requested to post their question in the chat box.
Ma'am, can I get recording of this?
Sorry, ma'am.
Can I get recording of this session?
Yes, ma'am. We are going live on YouTube as well. Okay, ma'am. I think there are no questions. Shall we move on, ma'am?
Thank you very much that giving me the opportunity, and so I can relate this ability of this Bhel Samhita related to Vishamjwara. Thank you very much.
Thank you so much, ma'am. I request Dr. Ajay Paul, Associate Professor, Department of Kaya Sikitsa, Ayurveda College, Coimbatore, to deliver the vote of thanks.
Hello, it's audible.
Yes, sir.
Good evening, everyone. It is my privilege and great joy for me to extend a vote of thanks for the today's session. I would like to express my sincere gratitude to Dr. Hrishita S. Madam for sharing your valuable experience on the topic of clinical concept of Vishamjwara Pathogenesis in Bhel Samhita with respect to CRS. I am sure that all participants are immensely benefited being there. Thank you so much. Last and but not the least, thank you to the all participants who are joined with us. Thank you.
Thank you, sir. It is the province of knowledge to speak, and it is the privilege of wisdom to listen. Thank you all for patient listening and the valuable time spent. To know more about our updates, please do stay connected with our social media platforms. That's all for today's most interesting session with a lot of new information for us to close our eyes with thought-provoking knowledge. Thank you all for joining us. Thank you.